This is chapter 27, face and neck injuries. So your face and neck are relatively vulnerable to injury because it's really unprotected overall. A lot of places in your body have bone to protect, and your face just doesn't have that because the bone's underneath. Some injuries can definitely be life-threatening depending on where they occur and how bad they are. Penetrating trauma like to the neck can certainly cause some pretty severe bleeding, and any open injury to the neck may allow for an air embolus to end up going into the circulation, and that can be absolutely devastating. With appropriate care, a patient, even with a terrible injury, can have a pretty good outcome overall. So going back through some anatomy and physiology, the cranium, it's first to the skull itself, contains the brain. The back portion of the head, just above the neck, is called the occiput. Then you have several different areas to the brain. Anterior to the ear and the temporal region, you can feel a pulse because you have an artery right there. We'll go ahead and just take a quick look at this. So your face, you've got your nasal bone, which is relatively short. You have the bony orbit that protects the eye, and it's made up of several different bones formed together. You've got your exposed portion of your ears is actually only covered by cartilage, so you don't have any bones there. And then you've got the movable mandible joined with the maxilla to form the jaw. Here's some of those joints that are particularly susceptible to injury, kind of showing where they are. Your temporalmandibular joint, that's where your mandible joins in with the rest of your skull, and it can definitely be very easily injured. About 1 inch to the posterior of the ear is the mastoid process. So that's more of just a landmark point than anything else. The neck itself, you have tons of important structures. The cervical spine, those top 7 vertebrae make up your cervical spine. The spinal cord exits from the foramen magnum at the bottom of the skull and then lies within the spinal canal formed by those vertebrae. You have a lot of structures, including the esophagus and the trachea, that lie in the midline of the neck. The trachea obviously caudal to the esophagus. In there, you've got a lot of veins as well. You've got your jugular veins, you've got several nerves. You also have your carotid arteries, and here's a pretty good look at that. Everything's pretty close within the neck. It's pretty packed in there. So an injury to one structure typically leads to injury to more than one structure overall. You've got your trachea, which is relatively tough because it's got a lot of cartilaginous rings. You've got your thyroid and cricoid cartilages, which give your trachea quite a bit of structure, but it can rupture as well. You have a lot of musculature that supports the neck. The big one is the sternocleidomastoid, and it literally follows that track. It's attached to the sternum, to the clavicle, and then up to that mastoid process, or vice versa. It originates from the mastoid process, but that's how it comes down. It allows you to turn your neck. So when we have a lot of very quick motion with the neck, that tends to be what ends up getting injured. Your eye is about 1 inch in diameter. It's semi-rounded. For those of us that end up wearing glasses or contacts, we have some sort of abnormality in the roundness of our eye. The orbit protects about 80% of the eyeball itself, but it still is susceptible to injury. Within the eyeball itself, there's several different structures, which we did already go over in the A&P portion. But just to kind of reiterate, your eye is filled with liquid, and there's two different types of liquid. One is more viscous than the other. You have your conjunctiva, which cover the eye, like the eyelids, and that can be susceptible to injury. And then your retina, the part that actually has nerve endings. They respond to light by transmitting those to the optic nerve. And so your brain can interpret sight. That is actually only held against the structures on top of it by pressure. So even if you don't damage the eye itself per se, a good enough smack can cause retinal detachment. Here's another picture of some other structures that we have. You've got the lacrimal gland that ends up putting tears across your eye. They drain into the nasolacrimal duct. Again, why you end up having a runny nose when you end up crying. The sclera is that white fibrous tissue. It actually maintains the globular shape. On the very front of the eye, you end up having that clear membrane, the cornea, that allows light to enter the eye. And then you have some muscles right behind that that cause your pupil to either dilate or constrict based on the amount of light that's available. Ansecoria is a condition in which a person is born with different sized pupils. So just because somebody has different sized pupils, you need to ask them if that's normal for them or not, because it can easily be mistaken for intoxication or head injury. Or it could be a cataract surgery as well. We talked about the retina already. Retinal detachment causes blindness. The retina has a lot of blood vessels running through it as well. So pretty important structure for the eye overall. Different injuries of the face and neck. Injuries to the face and neck can often end up compromising the airway. Can be partial or a complete obstruction. And there's several different factors that can contribute to that. If you've got heavy bleeding, the blood itself can become an obstruction or blood clots forming from that bleeding. Direct injuries to the nose, mouth, larynx, or trachea are often a very big source of significant bleeding. Can also cause respiratory compromise. Injury to the teeth or dentures may cause those portions to fall down into the airway to get end up lodged there. Swelling, if you have a lot of swelling because of either an indirect or a direct injury, that could certainly cause airway obstruction. And the airway may be affected depending on the position the patient is in. If you turn them from one side to the other, that certainly can cause them to have compromised. And then sometimes injuries to the brain or cervical spine can interfere with normal respirations because our control center for breathing is up very close to the base of our spinal cord, which is coming right out of the skull. So a cervical spine injury can cause some issues with bleeding or with breathing, excuse me. Soft tissue injuries are very, very common for the neck and the face. The face and neck are extremely vascular, so it tends to cause a lot more swelling. It tends to have hematomas. They look a little bit more gruesome because the skin and neck have a very rich blood supply. Oops, sorry, my bad. Dental injuries. The mandible is common for a dental injury just because it's got a lot of prominence. And it comes secondary to like nose injuries, nasal fractures, as far as frequency. Most of the fractures result because of vehicle collisions or assaults. It's those blunt force, high energy impacts that will show you a lot of broken jaws, unfortunately. And fractured or avulsed teeth are very common with facial injury. Remember that those teeth fragments can become an airway obstruction, so we need to remove them as quickly as possible. For your patient assessment, we always want to assess the scene just like everything else. You may want to end up throwing on some eye protection, maybe a face mask, because projectile blood happens. If you've got somebody that was in a car crash, they're bleeding from their face. If they sneeze, if they cough, it's very likely that you're going to catch some spatter, unfortunately. We're definitely going to see if we need additional assistance for BLS providers. If you're on scene with somebody that has the potential for an airway obstruction, there's not a whole lot besides basic support that you're going to be able to do for them. ALS can certainly have more options of airway control. So be very cognizant of, can I control this if something happens? If it's simple suctioning, yeah, you guys can do that, not a problem. If it's positioning, same thing, you guys can do that. But if there's significant bleeding, if there's injury to the trachea, you might need some additional help. Your primary assessment, you're looking for those life threats. Any threats to ABCs must be treated immediately. When there's life-threatening external hemorrhage and you know that they could bleed out, go ahead and address that first, throw a quick tourniquet on, and then move on to airway and breathing if necessary. Form a general impression. Again, you guys will get some experience and you'll get those spidey senses or gut feeling, whatever you want to call it, that you're looking at somebody and you're like, this is not good. The vehicle, while it gives you some information, may be deceiving. I found in my career that those vehicles, they're like, nobody is walking away from that. The injuries tend to be relatively mild, and the ones where you're like, I don't know why we're here. I can't believe somebody called us. And then all of a sudden they are beat up. I don't know why that happens. I think the more mangled the car, the more energy it's absorbed. The less mangled the car, the more energy that was transferred into the patient. That would make sense. But truly, the car is not your end all to be all. You want to ensure your airway is clear and patent, that they can go ahead and control it themselves. Look for any injury to the face or throat, but you may need to remove a collar or a hat or unzip a coat to make sure you can get eyes on it. Consider your need for manual stabilization, check for responsiveness, and then control massive blood loss with direct pressure. We'll go ahead and stop here and go on in the next one.